Welcome, everyone. My name is Elizabeth Olson. I am the program manager for our clinical program at the California Prevention Training Center. Thank you for joining us today for the STD clinical update titled Congenital Syphilis Scenarios, a case-based overview. Presenting today, we have Drs. Elizabeth Partridge and Dr. Rosalind Plotzker. A little bit about the California Prevention Training Center. We are housed at the University of California, San Francisco. We are a multidisciplinary training and capacity building assistance center. We are funded by the CDC, and we are part of the national network of prevention training centers that provides virtual and in-person trainings, technical assistance. We build clinical tools, and we provide an STI consultation service. There's some websites listed here for you to see. Again, we do provide STD clinical consultation. There's a network across the United States, and we run that consultation service for our region. And the website is here. If you are not familiar with it, we call it the warm line. You can provide a question here, and we have topic experts that can provide you with an answer anywhere from 24 hours to 5 days. Please note that the 24-hour is reserved for very pressing cases. This is our financial disclosure. We do not have anything to disclose today. This is our CME disclosure. There are 1.25 units available today, provided that you meet the criteria. So to earn the 1.25 units, this is the overview. You will need to have registered on the NMPTC site. Registration is now closed. Your attendance today is being recorded via Zoom. You will need to attend in full today. And also, when you registered on NMPTC, that email address is an email address that a survey will go to that you will need to complete. You will receive that survey in about 24 hours, and you will need to complete that survey by May 5th, giving us feedback on the webinar today to be eligible for CME. Once you complete those steps, you will receive an email from our email here at CPTC, which is captc@ucsf.edu, and you will receive an email instructing you to download your CME certificate. If you do not receive the survey request or the link to collect your CME, please do check your spam and trash box. Better yet, add this email address to your safe senders list so you can be ensured to get your CME. After this webinar, you will receive, provided you were providing your email address on both Zoom and NMPTC, you will receive a handout of today's slides, and there's no need to reach out to us for that. If you're logged on today, you will receive an email with a PDF version of these slides. Just a little bit of Zoom housekeeping. The Q&A function is turned on today, but your cameras and mics are turned off as well as chat. To submit a question, you'll see a Q&A icon. You can go in there and submit your questions. We will field some of them. We'll just type in an answer. Others we will save for the end of today's presentation and do our best to answer all of the questions to the best of our ability. We'll leave about 10 to 15 minutes for Q&A at the end of today's webinar. If you have any questions, you can submit them to myself at this email address. And after that, I would like to introduce our honorable speakers today. We have Dr. Elizabeth Partridge. She is an associate clinical professor of pediatric infectious diseases at the UC Davis Medical Center here in Sacramento. She provides both inpatient and outpatient consultation for children with acute and chronic infections. She serves as the medical director of infection prevention for the UC Davis Children's Hospital. Her clinical and research interests include hospital epidemiology and infection prevention, and she has a particular interest in the prevention and management of congenital syphilis infection, which we're covering today.
Elizabeth, I'm sorry to jump in. Hello, everyone. I'm Kelly Johnson, Medical Director, California Prevention Training Center. The sound is a little bit off now. Can you move the mic maybe a little bit closer to your mouth?
Strange.
Yeah, that's better. Perfect.
Okay. Sorry about that. Um, it's also my honor to introduce Rosalind Plotzker. She is one of our faculty here at the California Prevention Training Center. She is the assistant professor in the UCSF Department of Epidemiology and Biostatistics, and she also performs high-resolution endoscopy at the UCSF Anal Neoplasia Clinic Research and Education Center, also known as the Anchor Center. She completed a fellowship with us here at CAPTC in sexually transmitted infections in conjunction with the California Department of Public Health. She serves as a public health medical officer at the STD control branch at CDPH, in addition to her role here at UCSF. So without further ado, I would like to give you Roz and Elizabeth. Thank you both for being here today.
Hi, everybody. It is great to be here, and Elizabeth will be sharing her slides. So give us 10 seconds. There we go, less than 10. Elizabeth Partridge and I will be going over congenital syphilis cases that illustrate the different scenarios. Next slide, please. We have nothing to disclose, no financial disclosures. So by the end of our talk today, there are 3 main learning objectives we hope you'll take away. The first is that we want you to be able to describe the different diagnostic criteria for the 4 scenarios, which are described by the CDC. In addition to that, we want you to identify at least one public health resource for CS management. And spoiler alert, we will be featuring one over and over and over throughout this talk. And our last learning objective is that we hope that you'll understand the different diagnostic tests and evaluations that can be used when you're evaluating an infant who was exposed to syphilis during pregnancy. So those are our main learning objectives. And with that, I'll hand it over to my colleague, Elizabeth Partridge, for the first case.
Hi, everyone. Thanks so much for coming. The first case, I received a call from the NICU about a 1-day-old female born at 36 weeks, small for gestational age, with an enlarged liver and spleen, and a peeling rash like the one seen here in this picture that was on her chest, as well as on her palms and the soles of her feet. She was born outside the hospital at a homeless encampment and brought to the hospital within a few hours of birth. Her mother had some significant life challenges, including housing insecurity, drug use, in this case it was methamphetamines, limited prenatal care, and she did not have a known history of prior syphilis evaluation or treatment. So at the time of delivery, mom had a treponemal antibody test that was positive, an RPR of 1 to 128, and infant's RPR was 1 to 32. And this is our beautiful CDPH congenital syphilis management guideline. Roz, do you want to take a minute to give an overview of this? Oops, I think you might be muted.
Sorry. Hi. I would be delighted to. So this was an algorithm that we developed in CDPH. Basically, it walks you through the different steps for evaluating an infant who was exposed to syphilis during pregnancy. And please note that this is for infants who are less than 30 days old. The first thing that you want to do is right where that start box is. You start with doing RPRs for both the infant and the birthing parent or mother. And then you first start by doing infant criteria, which Elizabeth will go over in this case. One thing just to know for this algorithm in general is that the top boxes are about evaluating the criteria, and then the lower boxes are about evaluation in terms of doing tests or not. And then you see treatment at the bottom. Okay.
So great, thank you, Roz. So for scenario one, a baby is proven or highly probable to have congenital syphilis if they have at least one of these infant criteria. So if we think about our case, she had physical exam findings consistent with CS. She did not have a greater to or equal than fourfold higher maternal titer. That is an infant criteria. And then the other two criteria, positive dark field, PCR, silver stain, these are path tests that aren't routinely done anymore, but are, when they are done, are possible criteria for the infant. So in terms of evaluation, scenario one infants, the recommended evaluation is to get an LP done to look at the CSF, to get a CBC looking for anemia or low platelet counts, and to do long bone radiographs looking for bony changes. Other tests are done as clinically indicated. And then in terms of treatment, all scenario one infants require 10 days of IV aqueous crystalline penicillin G, which of course requires a hospitalization and most often requires a central line.
I have a question.
Yes, please.
What other, so you mentioned the hepatomegaly, rash, what other physical exam findings would be concerning for CS if this infant came in with some other physical finding? What would tip you off?
Absolutely. Thank you for that. So I wanted to share this figure was made by one of my colleagues, Dr. Gianna Bautista. And I like this because it shows the symptoms of untreated CS at different time points. So you can see evidence of CS prenatally, in the newborn stage, and if left untreated, in childhood and beyond. And so here are some examples of early clinical manifestations of CS. So as early as the second trimester ultrasound screening, you can see placental thickening, you can see hydrops and growth restriction. These infants can be born preterm or small for gestational age. These are some of the pictures that you can see of skin findings, and this is a nasomucosal picture of these secretions that you can see. And they can also develop neurologic disease. So that can include things like meningitis, developmental delay, hearing loss. You can see bony involvement. So these are pictures of periostitis, and then osteochondritis. And interesting, this usually presents as the infant sort of having pseudoparalysis, so not moving an extremity, but it's not because of a neurological deficit, it's because those bony lesions can be really painful. CS can also affect the lungs, the heart, the GI tract. The most common GI clinical manifestation I see is the hepatosplenomegaly. And then if left untreated, children can go on to develop late manifestations. So neurologic disease, eye disease. So you can see here a picture of the interstitial keratitis. You can have eighth cranial nerve deafness. It affects connective tissue. So you can see dental abnormalities like the Hutchinson teeth shown here, or progressive skeletal abnormalities seen here in the shins and in other joints. Question, yes.
I have another question. You also mentioned that there was additional workup as clinically indicated. What does that mean? How is it helpful?
Yeah, thank you for that. I get that question all the time. So as I mentioned, for these scenario one infants, there are three things that are recommended that be done: the CSF, the CBC, and the long bones. So let's go over the results for this infant. So this infant got a successful lumbar puncture, just a few red blood cells, so not affecting the whites of the protein, but had elevated white cell count and elevated protein, normal glucose, but a positive VDRL. So very consistent with CNS disease due to syphilis. The CBC showed anemia and low platelets. The bones showed destructive bone lesions. All babies, when they're discharged from the birth hospital, get hearing exams. And so this is a routine test that this baby had, and luckily she passed. But the clinical team was concerned that the baby wasn't tracking well, and so they got further ophthalmology examination done. That was normal. If it had been abnormal, that would inform follow-up, outpatient follow-up for the baby. Another test that was done based on a clinical exam, baby had enlarged liver and spleen. They got a chemistry that showed high bilirubin. That bilirubin informed phototherapy. So that's what we mean in terms of other testing as clinically indicated. So baby was treated with 10 days of aqueous crystalline penicillin G IV. And the current guidelines recommend repeating RPR until non-reactive. Baby came to our clinic at 2 months of life, and baby was non-reactive. So this was an infant that had some abnormal physical exam findings due to congenital syphilis, but most babies with congenital syphilis are asymptomatic, and they come to across your desk, Roz, because of other reasons. Could you tell us about one of those?
Yeah, I would be delighted to. Next slide. So for our second case, and just to give a little bit of context for our viewers, I work in a health department, and when we have people come to us, it's typically someone at a local health department, like a county, and they're working on a case. So we actually get a little bit more information that dates further back to include the pregnancy itself. Next slide. So our case actually starts in the prenatal period. This is a 26-year-old pregnant patient who's a G3P1, meaning they've been pregnant 3 times, they've had 1 living child, and they live in a high CS morbidity county. So our story starts with the first prenatal care visit, which happened at 16 weeks gestation. At that first visit, they were appropriately screened for syphilis using something called an enzyme immunoassay or an EIA. And that test is non-reactive. That test tests for something called treponemal antibodies. If you've ever had syphilis, it will come up positive, and ours came up non-reactive, which is reassuring. Besides living in a high CS morbidity county, they had no individual risk factors. So Elizabeth, your case, you mentioned that there was housing instability, there were social factors. Our case denied drug use. There was no housing instability. They did not have multiple sex partners. They were not living with HIV. That was actually confirmed twice during pregnancy. And they had 1 male partner who also had no risk factors for syphilis. Okay, so this is where we're starting. Next slide. The patient's next syphilis test was during the 3rd trimester. So this was at 27 weeks and 4 days gestational age, and they were appropriately screened in the 3rd trimester. This time they were screened again with the EIA, but this time it came up positive. So if you look to the right, you'll see something called the reverse screening algorithm. And what we do is we start with the EIA or CIA, which is a chemoluminescent assay. If that's negative, then we stop there, which is what it was in the 1st trimester. However, if it comes back as positive, then we need to do more testing. And the next test we do is an RPR. That is a non-treponemal antibody, and basically it goes up and down. It helps us to quantify the burden of disease. And if that RPR is also positive, then we have a positive non-treponemal test and a positive treponemal test. And those 2 things together are what we need to diagnose syphilis. And that can be either a history of syphilis that was treated, or it can be untreated syphilis. And so at that point, we need to do a little more digging in the history. But for this case, the RPR was non-reactive. And so if there's a non-reactive RPR, then that could mean one of 2 things. It could mean that this patient, or it could actually mean one of 3 things, but the two most common ones are that either this person had syphilis before, it was adequately treated, and now their EIA is still positive because it'll stay positive for life. That's option one. Option two is that the EIA could have been a false positive. And the way that we figure out if this EIA is a false positive or not is we do a second treponemal test. So in this algorithm that you see outlined, they use a TPPA. However, if they, in our case, they used a different treponemal test for the confirmatory, which was an FTA ABS, and that was non-reactive. And so because that was non-reactive, they decided, okay, that first syphilis test was probably a false positive. And so they diagnosed it as a false positive in the third trimester. Next slide. Okay, so now we have a patient who's had a false positive in the third trimester. They come in for delivery, 38 weeks full term, and 4 days. She came in with a rupture of membranes. She was in labor. They did think to do a test at delivery as well, which was recommended for all high morbidity counties at the time. And again, we see our positive EIA, our non-reactive RPR, and then a non-reactive FTA ABS, which is a confirmatory. So again, they would have diagnosed this patient as false positive. On physical exam, there were no signs of syphilis, no rashes, no concerned chancres, anything like that. It was a normal vaginal delivery, and the family was discharged home on postpartum day 1. Okay, next slide, please. So I've been talking about, testing in the first, testing in the third, high morbidity county. There's an exciting update that when this case was happening, this was prior to October 2024. But because this patient was living in a high CS morbidity county, CDPH was recommending that all people in high morbidity counties be screened once in the first prenatal encounter, again in the third trimester, and again at delivery. Now that has expanded to the entire state. So it doesn't matter what county you live in. As of October 14th, 2024, CDPH recommends that everybody get screened in the first, third, and at delivery. Okay? All right, next slide, please. So what happened to our kid? At delivery, the infant was a little over 3 kilograms, APGAR 9 and 9, no symptoms, looked like a healthy infant. And like I said, was discharged to home on postpartum day 1, no treatment. However, because of that positive EIA, a pediatrician thought, we should test this kid just to be sure. And so they did an RPR, which is what you want to do for infants when there's a concern about being exposed to syphilis. And the RPR came back positive on the infant. It also reflexed to do a TPPA, which is that other TREP test I mentioned. You wouldn't normally get a TREP test on an infant, but in the lab, they reflexed to do the TPPA, and that came back as undeterminate. These results didn't come in until postpartum day 2. So this happened after everyone had gone home. Yeah. Yes, comment.
This is a really good, astute clinician, in my opinion, that got this RPR for the infant, even though it was thought that mom's initial testing represented a false positive. So I just think this is excellent.
Yes, great job, clinician. It doesn't hurt to get the RPR. TPPAs, you don't want to screen with a TPPA because if a maternal TPPA is positive, it can be transferred to the infant very easily, and TPPAs can take up to 15 months to go back to non-reactive. But I think the RPR, it was a good call. So what do we do with this? First, what do we do with this indeterminate TPPA? There are a couple reasons why someone might have equivocal or indeterminate TPPA. Again, remember these measure antibodies that are specific to syphilis. So It could be that this is a very early infection. That's a possibility. And that the antibodies are still quite low, and so it results as equivocal or indeterminate. It could be a false positive. TPPAs can be false positive. It's much less likely than EIAs, but it's possible. It could also be the result of a previous syphilis infection, either untreated or treated. You know, the level of TPPA antibodies or treponemal antibodies can decline over time. And so if someone has had syphilis a long time ago, their TPPA might go to become indeterminate, which wouldn't be the case in an infant. And number 5 also wouldn't apply here, but it could be due to another treponemal infection like yaws or something like that. Excellent. Thank you so much. So our beautiful algorithm. So as Elizabeth Partridge outlined for the pink boxes, the first thing you do is look at the infant, but we know that our infant did not have any CS findings on physical exam. The RPR was higher than the maternal RPR, but going from non-reactive to 1-to-1 it's a single dilution, so it wouldn't be considered 4-fold increase. So actually that would not be considered a scenario 1 criteria, although it gets debated all the time. And you know, we don't have any lab results or dark field or silver stain of placenta cord to go off of. So the answer is no for all of the infant criteria. And so then we move on to the maternal criteria, which is the orange box. Next slide. Okay, so here are the first orange boxes. For maternal criteria, we want to see if this mom or pregnant patient was treated or not. And essentially, if they weren't adequately treated, so either they weren't treated at all, they were treated but not completely, they say they were treated but it wasn't documented, or they were treated but it wasn't with a benzathine penicillin G regimen, or they got their treatment late in pregnancy within 30 days of delivery. If any of those are true, then that would be considered a scenario 2 or possible congenital syphilis case. In our situation, we have to err on the side of caution and say, you know, this kid had a positive RPR and maybe maybe TPPA positive. So we have to assume that this is a person who had syphilis prenatally and was not treated. So that's what they did. Going with that line of thinking, they did the workup that's outlined here, which is essentially the same as what you would do for a scenario 1 infant, with the exception that you don't need to do tests as clinically indicated because the baby looked normal. That's why they're not a scenario 1. So this infant would have been indicated for a CSF, a CBC, and a long bone X-ray. Next slide. The difference here is that with a scenario 1 infant, regardless of the result, the scenario 1 infant is going to get IV penicillin. They're going to have a central line placed, they're going to go to the NICU, and they'll get IV penicillin because the physical findings alone or the high RPR alone is enough that you would worry that the syphilis could involve the nervous system. And so you want that infant to get IV penicillin that can include nervous system treatment, and it will prevent neuro involvement. For scenario 2, the infant looks normal. And so now it really depends on if any of these tests are abnormal. If any of the tests are abnormal, that tells us that there's a higher likelihood of neuro involvement and you need to do IV penicillin, just like you would for a scenario 1. Also, if you don't have a result available, so let's say you try to do a lumbar puncture, but you don't get CSF, and so you just don't know if the CSF is normal or not, CDC says, err on the side of caution, give this kid IV penicillin. Or if follow-up is uncertain. So if the tests look normal, but follow-up is uncertain, you don't know if you'll see the kid again, then also err on the side of caution and give IV penicillin. That said, if there are no abnormalities, you have all the test results, and follow-up is certain, then it's fine to give the kid just a single IM dose, intramuscular dose of penicillin G, which is benzathine penicillin G. It's different than aqueous crystalline. Okay, next slide. Okay, so what happened to our baby? On postpartum day 19, an investigation was created by the health department. So the test results were sent electronically to the health department, and they eventually created an investigation. The next day, they called the family, and the infant was admitted to the Children's Hospital for workup appropriately and treatment. On workup, the EIA was positive, the RPR was 1-to-1, and so we have our positive TREP test, our positive RPR. The infant had normal CSF, normal long bone X-ray, normal blood work, and so they received an intramuscular dose because the workup was normal. So once we found out the results, we could give a normal, we could give an IM dose. As for the parents, both of the parents received their first dose of bicillin, and the mom, MOB is mother of baby, FOB father of baby, was retested. And this time the EIA was positive, RPR was non-reactive, but this time instead of that FTA-ABS, they did the TPPA, which is again another treponemal test, but this was different from the FTA-ABS that they did initially. And this one was positive. So this actually confirmed that, yes, there is a history of syphilis. Next slide. Yes, Elizabeth.
So I have a question about these test results.
Yeah.
Why would a TPPA be positive if the FTA-ABS was negative, is my first question. And
Okay.
then how do we account for the maternal RPR being non-reactive, but the RPR for the infant was reacted at 1-to-1?
I know. This is my whole job, is teasing these things apart. It's really frustrating and it's really confusing.
Yeah.
They're really good questions that we get a lot. Next slide. If you go to the next slide, there's a table. So this table is from a study that was published in CID in 2020 by Ina Park, who's also with the PTC. She's our PI, and her colleagues. And this looks at the different sensitivity and specificity for different treponemal tests. So if you press the spacebar, you'll see I highlighted the FTA, ABS, and the TPPA. And what I want you to notice is that the sensitivity, meaning the ability for a test to detect syphilis, is different for FTA, ABS, and TPPA. The FTA, ABS, especially in late latent syphilis, is low compared to TPPA. So for an FTA, ABS test, there's like an 85 to 93% chance that you'll detect syphilis if you're testing someone with late latent disease like our mother of baby. The TPPA late latent ranges from around 87 to 100% sensitivity. So basically TPPAs are more sensitive. The other thing that's really nice about TPPAs is that they're very specific. So the specificity of a TPPA is 99.6 to 100%. So if a TPPA is positive, that is because of syphilis, unlikely to be because of something else, compared to FTA-ABS, where the specificity is like 87 to 100%. So it could be due to a different disease. So that's the first question. The second question you had was about the RPR and the non-reactive versus 1-to-1. So there's, it's a tricky question. RPRs are not perfect. RPRs can go up and down, and especially for patients with very, very, very low levels of non-treponemal antibodies, they can kind of waver between being non-reactive and one-to-one. So it's possible that the one-to-one could be due to a transfer of the maternal antibodies that were detected in the infant but not detected in the mom. That's a complete possibility. Another thing to think about, which wasn't true for this case, but could be true in other cases, is to think about where the blood from the infant came from. Cord blood samples can be contaminated, and so you would want to check, is this a cord blood sample from the umbilical cord versus an infant serum sample? Serum is always a better reflection of the infant's non-TREP antibodies versus the cord blood, which could include maternal antibodies as well. So yeah, next slide. Oh, you are welcome. Okay, so with all that, I heard you have a third case for us.
Yes, I do. Let me jump in. Okay, so for this case, I was called when the baby was 3 days old, was a full-term infant, and his exam was entirely normal. He was born in the hospital by vaginal delivery. Mom was incarcerated at that time, and reportedly she remembered being treated for syphilis during her pregnancy before she was incarcerated. But the NICU team that called me didn't have documentation of that prior maternal treatment. So here's what they had. At 7 months into her pregnancy, when she was booked, she was tested and she had a positive treponemal antibody and an RPR of 1 to 4. At delivery, her RPR had gone up to 1 to 8, and baby's RPR at delivery was 1 to 2. And so here we are at our beautiful algorithm again. And again, this infant had a normal physical exam, a low RPR titer. These other stainings were not done. So we were looking, like in Roz's last case, at maternal criteria. And mom thinks she was treated, but the NICU doesn't have documentation. So basically, the NICU team was treating, basically thought that the maternal criteria was met and that there was no treatment that was documented. So this infant was essentially being treated as a scenario 2 infant, which, as Roz just went over, so by the time I was called, baby had 3 attempted lumbar punctures. Ultimately, those lumbar punctures were unsuccessful. CBC was done, long bones were done, those were normal. A central line had been placed, and baby was being started on what would be 10 days of IV aqueous crystalline penicillin G, because, as Roz stated, part of the workup had been unsuccessful. So when we have an incomplete workup in a scenario 2 infant, they were treating as a scenario 2, you give 10 days. So that's what they were doing. Mom had been discharged back to custody, but there was still this question about mom's prior syphilis diagnosis and treatment. And so I was thinking, is this really unknown, or was it unexplored? And so I wanted to just pause and emphasize, from my perspective, how important getting a complete maternal syphilis history is for the management of these infants. And what I routinely see in my practice is that clinicians are underutilizing 2 really important ways to get information, important sources of information, and that's talking directly to the mother and accessing the county public health records. So the mother can tell you some really important demographic information, which can be helpful. So all of her names that she's ever gone by. We often won't find that in the electronic medical record, but she can tell us her date of birth, all of the counties that she's lived in while she's been sexually active, things like her sexual activity or partner history, risk factors for congenital syphilis that can be helpful. And then with this demographic information, you can take this to the public health departments in the county she's resided in, and they can give you information on prior syphilis testing and treatment history. So for example, in this case, we were able to get updated information that was really critical. So it turned out that at 4 months into her pregnancy, mom presented to the ED. She had a chancre on exam and had reported a new partner with known syphilis infection. She received a benzathine penicillin dose in the ED, and the testing done at that time showed a positive treponemal antibody and RPR of 1 to 32. So this is a reminder slide. What is adequate treatment for syphilis during pregnancy? It's penicillin all the way. The treatment for syphilis acquired within a year, so that would be primary, secondary, or early latent, is a single dose of 2.4 million units of benzathine penicillin G IM. If syphilis is acquired more than a year ago, or if the duration of infection is unknown, then appropriate treatment is 3 of these IM doses, separated ideally by 7 days, but 6 to 8 day interval is also acceptable. So the timeline for this case, mom was actually appropriately treated for primary syphilis with a single dose of IM benzathine at 4 months gestational age. 3 months later, she's incarcerated, gets screened again, has no symptoms. Her RPR is beautifully downtrending, so doesn't need any more treatment. And then at the time of delivery, she has no symptoms, but her RPR has gone up 1 to 8. So like Roz had been beautifully articulating earlier, this is a twofold increase in titer, just 1 dilution. So not clinically significant. This difference is within the margin of lab error, or it could also reflect slight variations in maternal antibodies themselves. So now that we have this complete maternal history, we know that the infant actually meets scenario 3, less likely congenital syphilis, because mom was adequately treated greater than 30 days before delivery, and we have no concern for reinfection or treatment failure. So baby did not need further evaluation. In terms of treatment for these scenario 3 infants, we first review maternal titers and stage. So if mom had an equal to or greater than 4-fold decrease in titer after treatment for early syphilis, or if she had a stable low titer, so less than RPR 1 to 4, or VDRL less than 1 to 2 for latent syphilis, and if follow-up is certain, then no treatment is indicated. But if either of these two maternal titers is not true, or if follow-up, really importantly, if follow-up is uncertain, then the recommended treatment is benzathine, a single dose. So unfortunately, this infant had some unnecessary things happen, right? Unnecessary hospitalization, unnecessary procedures. So we stopped the unnecessary treatment. We removed the central line. I felt most comfortable because I didn't feel like follow-up was entirely certain that we give benzathine 1 dose, and baby was discharged home with foster parents. And baby did represent at 2 months of life though, and RPR was non-reactive. So in this last case, the mother had syphilis that was appropriately treated by stage during pregnancy, starting at least 30 days prior to delivery. Roz, what about pregnant patients who were appropriately treated prior to the current pregnancy?
Great question. And also a really great case. I was like on the edge of my seat the whole time, even though we reversed it. I was like, wait, what's gonna happen? No, I'm so glad you were able to see the infant, because I think that I think in that last case, you know, you don't know if you're going to see an infant again. And I think it was 100% the right call to treat the infant. And also, I think so highly of you for reaching out to the health department as someone from the health department.
Yeah, partners. We're partners in this.
Partners in syphilis in a good way. Okay, next slide. So for our grand finale, I do have one more case, and that is a case that came to us from the STD CCN, which was highlighted in the beginning of this talk. Next slide. And so the STD CCN is the STD Clinical Consultation Network, and people write to us, and 2/3 of the time the question is about syphilis, and 2/3 of those are about congenital syphilis. So here's an example. This came from the health department. The mother of this infant, or MOB, mother of baby, was screened with the reverse screening algorithm, which we went over already. The EIA was positive, the RPR was non-reactive. They did a TPPA, which was positive and confirmed the first test, right? The infant was non-reactive. The infant had no signs or symptoms. So the person who sent this request was very astute and reviewed the maternal history and saw that this parent also had negative RPRs in the first and third trimester, just like my last case that I presented. And so they've had non-reactive RPRs throughout pregnancy. They also went to the surveillance records, and it showed that the mother of the baby was adequately treated for late latent syphilis. And this was 10 years earlier, so way before they got pregnant, and there hasn't been any risk of infection since. Next slide. So this is not on our algorithm because this person did not have syphilis when they were pregnant, and this infant was not exposed to syphilis during pregnancy. So this is CS unlikely. Essentially, it's someone who's had syphilis in their lifetime that's been cured. So the definition is any neonate who has a normal physical exam, a serum quantitative non-TREP serologic titer equal to or less than 4-fold the maternal titer at delivery, which, you know, both infant and pregnant patient were non-reactive, plus both of the following. The mother's treatment was adequate before pregnancy, check, we found that, and the mother's non-TREP serologic titer, in other words, the RPR or VDRL, remained low and stable before and during pregnancy and at delivery. So in our case, the RPRs were non-reactive, definitely less than 1 to 4. Next. So CDC says no treatment is required. However, any neonate with a reactive non-TREP test, so if you did the RPR and it did come back positive, should be followed to ensure that the non-TREP test goes back down to negative. So you want to follow infants to non-reactive if they have a 1-to-1, say, or something like that. You could give the intramuscular injection of benzathine penicillin G as a single injection, especially, again, if we're not sure if we'll see the infant again. So a follow-up is uncertain. And if the infant has a reactive non-TREP test. So our case, non-reactive RPR, no treatment necessary. We can go home and rest assured that this is, you know, okay. Next slide. Okay, so to summarize, a couple quick points. For our first case, CSF, long bone, X-rays, CBC are the minimum workup. Elizabeth did a really nice job of outlining other tests that could be done as clinically indicated. So in our first case, we had someone with hepatosplenomegaly. Their tracking wasn't great, and so they got a ophtho exam and they looked at the bilirubin. Okay. For the second case, there were 2 take-home points. First is that a positive EIA, which is used in the reverse screening algorithm, could be a false positive. And so if the RPR is non-reactive, you want to confirm that first test, ideally with a TPPA. That's the best test for confirmation. Also, not every scenario 2 infant needs IV penicillin. I know it's very tempting to send everybody to the NICU for IV penicillin, but if the workup is okay and follow-up is certain, doing a single dose of IM treatment is fine. For Elizabeth's second case, which was case number 3, maternal histories are very important. So if you can, dig deep, and health departments and the people who work there are your friend. For the last case, infants born to patients who were previously treated for syphilis, and if the RPR during pregnancy remains low, between non-reactive and 1 to 4, those cases do not require a workup, and they usually do not require treatment. And that, our next slide, that concludes our cases. I just want to highlight a couple of resources. We talked about STD-CCN in the beginning in case 4. It's a great resource. I'm one of the faculty. Kelly Johnson is one of the faculty. We have lots of really wonderful faculty who can help you work through complex STI cases. The California Department of Public Health STD Control Branch Congenital Syphilis page is a treasure trove of information. The CS algorithm that we keep coming back to is there, as well as a lot of other resources related to CS. Next slide. And we have a brand new resource that literally just got posted next week, and I am so excited to highlight this. CDPH worked with a county to create a prenatal clinic specifically for preventing congenital syphilis, called Pregnancy Connections. And this clinic was successful. It worked with people who were primarily unhoused and people who were using substances during pregnancy, and or had diagnosed syphilis during pregnancy. And so it was a wonderful project, and we wrote a guide for how to make similar clinics. It has instructions, it has tools, it has templates that can be adapted. So if you're interested, or your jurisdiction is interested in making a similar clinic, it's up on CDPH's website. The direct link is there, and you'll be getting these slides via a PDF after this lecture. So please take a look at that if that's something that interests you. And finally, a short list of several wonderful colleagues in alphabetical order by last name: Sharon Adler, Lauren Blackley, Wyatt Hamp, Kathy Jacobson, Kelly Johnson, Curtis Moore, Elizabeth Olson, Ina Park, Eric Tang, who've all had a really important role in our work preventing CS for the past several years. And that's it. Thank you so much. What questions do you have?
Thank you, Elizabeth and Roz. That was excellent, very comprehensive, and I like that you picked some tough ones. I was a little on the edge of my seat at times as well. There have been a lot of questions in the chat, and we're having more come in. I would say there were several about the different treponemal tests and the sensitivity and specificity. So I went ahead, and for anyone who's not looking at the chat, I put that paper in the chat if you want to check it out. It goes through like a bunch of different TREP tests and the sensitivity and specificity. Also, there's me on that slide right now. Hello, I'm the medical director for the California Prevention Training Center. Thanks, Elizabeth. And one other just question that came up in the chat that I just want to make sure we highlight, so we just level set and put everyone on the same page. Treatment of pregnant people with syphilis during pregnancy. What if they're allergic to penicillin? What do?
You give them penicillin, but you desensitize them first.
Correct. Yeah, totally. Just want to make sure we've said that. And now on to cases. I'm just going to kind of go in order. There were several questions about your second case and the sort of discordant treponemal tests.
Yeah.
So this person was troubled by the discrepant results and was asking about when that pregnant person first had that reactive EIA, why weren't we more cautious? Should the partner have been tested? Should the pregnant person have been brought back for repeat testing? What do you think about that?
Well, that's, the thing about EIAs, so a quick thing about EIAs. One is that false positives are not uncommon in pregnancy. The reason that we do EIAs in big hospitals or labs is that EIAs are automatic. So the other ones, the FTA-ABS, the TPPA, those are things that are read manually. And when you have a lab that's seeing a very high volume of patients, and there's a relatively low percent of those who would actually have syphilis, you do the EIA, which is automatic. So in general, we know that the rate of false positives for EIAs is higher than we like. I think I don't want to quote the exact number, but it's definitely more than TPPAs and FTA ABS. So we start with the EIA, it's positive. However, the FTA ABS and the TPPA are both much more specific. And so if you have to choose between an EIA that's positive or a TPPA that's negative, you choose the TPPA. So we do, that's why we do the confirmatory testing. And if you have a positive EIA and a negative RPR, then you do the confirmatory test specifically for that reason. And it's a good thing to retest them in the third trimester, right? And we did, and it was a false positive in that case. But you basically rely on the confirmatory test at that point. So I think what they did was appropriate. I don't know, Elizabeth or Kelly, if you have any other thoughts on it, because TREP tests are so tricky.
Yeah, I agree with what you're saying, that we have these algorithms for a reason, and sometimes there really are false positives, and you don't necessarily want to freak out, but you do want to do the right thing by the patient. Right. So the only other point I'd make is like, don't just rely on the serologies, like make sure you're asking the person, do you have any exposures to syphilis? Do you have any signs or symptoms of early syphilis? And if you're worried, empirically treat them and then repeat serologies like in 2 to 4 weeks to see if they change at all. But if all you have is an asymptomatic person who's like, I'm in a monogamous relationship, I don't have any symptoms, I don't have any exposures, and your algorithm says it's a false positive, then I think that's reasonable. And if you're clinically worried, you can always bring them back, say in 2 to 4 weeks, just to repeat and make sure you weren't like catching an early case that was in the process of seroconverting some of the other tests.
Right. Yeah. I think that's such a good point, that like when we were reviewing the case at the health department, like one of the things we were really careful about to look at was, are there any epidemiologic factors we need to think about? Is there housing instabilities or drug use? Are there multiple partners? Is there, but the one thing I think could have been different and would have made a difference in this case is if they had done the TPPA instead of the FTA ABS, which I think is just a better test and was recommended. So, but yeah, it's tricky. It's tricky how to manage it.
Yeah, definitely. But keeping in mind like the clinical scenario too. Yeah. Okay, on that same case, while we're still talking about case 2, I think this may just be a misunderstanding, maybe on my part, but this person is saying that in case 2 about the mom or the pregnant patient, if she was a late latent case, why did she just get a single dose of Pfizer?
She started so she came back and she got her first dose. But yes, she would have needed 3 doses. Yeah, she would have gotten 3 doses.
Got it. Okay. Yep. Great. Okay, and then here's one that does come up, and it's clinical and public health, so I'm wondering what you both think about this question. It's more on the side of the pregnant person, though. For mothers of babies where the mom has a prior treated infection, what's the general recommendation for the time period between RPRs? Essentially, they're asking, like, what if somebody has syphilis 8 years ago and they had an RPR of like 1 to 256 or something, and they got treated, but then they never got any follow-up, and you see them 8 years later and they have an RPR that's not non-reactive, it's 1 to 8 or something. How do you think about that? Could that be a reinfection? Did you miss it? Would you treat it?
My thinking is similar to your point about considering the context of what this is, what we're worried about. So if this is somebody who has very, very, very few risk factors, they were 1 to 256 8 years ago, they were adequately treated, and now they're here and they're 1 to 8, but they have like no risk for reinfection since that 1 to 256. They've never had any symptoms or anything like that. You do a thorough clinical exam. You could test that, and it also depends when in pregnancy you're testing, right? Like if you're testing in the first trimester, you could say, well, let's see what it looks like in the third trimester. I think it's probably, but if it's somebody who's had in that 8-year period, they've had multiple partners, they had a period where they were, unhoused, and they just were out of care for those 8 years, I don't think it would be unreasonable to treat them empirically if they had risks of infection. So I think it really depends on the context. I don't know what do you think, Dr. Partridge?
Yeah, no, I totally agree with you. And I think there can be some really great shared decision making that happens. I mean, my experience of working with these mothers, um, they want to do right by their kids and they want to do everything they can to have a healthy baby. And so I've been surprised, even moms that have like no risk factors at all said, look, I don't think there's a chance, but let's just do a treatment to be sure. And so I think absolutely getting the epi data and doing the three testing points if you get them early enough during pregnancy, first, third trimester, and then at delivery, but then also doing some shared decision making with the mom.
Yeah, that's a great point. And again, just a reminder to everyone, because we do get so many questions that are based on serologies. And of course, you need serologies when you're trying to do syphilis diagnostics, but you can't use them in a vacuum. You also need a clinical history and a story to figure out how worried you should be about different combinations of serologic results. Speaking of serologies, another question for you all. And I just want to do a time check. Elizabeth Olson, do we have 15 minutes still? Does anyone know? Is it still 15 minutes?
It's 101.
Okay, and we have till 1:15. Is that accurate?
That's what I was told.
Okay,
I
I
have
think
until
that's accurate.
1:15.
Okay, we'll just continue then, and obviously if you need to drop off, please feel free to do that, but we hope you'll stick around for questions. Okay, going back to serologies, and this is a question that I have seen come up quite a bit on STD-CCN. What if you're in like a case number 4 situation where mom is serofast, but she's serofast at something kind of high, say like an RPR of 1 to 8. How do you think about that? Do you sort of automatically, I feel like this is actually where I'm sort of landing, like, oh, that RPR makes me kind of nervous. 1 shot of Vicillin in the baby is probably not a big deal. Maybe we should just do that. But I'm curious to, especially from Elizabeth Partridge, how you think about that.
Yeah, so just make sure I'm understanding. So mom has come in and hasn't had the best prenatal care, so we don't have tracking, or has been 1 to 8 kind of persistently throughout pregnancy.
We didn't get all those details in the question, but let's just say she's
Yeah,
serofast at 1 to 8, and she's been serofast at 1 to 8. And I think what they're getting at is you had shown
the 1 to
the
4.
1 to 4,
Yeah, 1 to 4
like
is sort of
something
where we
low and stable. What if it's not low, but it's stable? Like, how do you?
Yeah, I
I would err on the side of caution.
yeah, I think that's reasonable to do. Absolutely. I am benzathine in an infant. It's very well tolerated. And obviously follow-up is an important part of this as well. Um, and also the clinical getting mom's epi risk factors. But yeah, I mean, and then the fact that RPRs are so tricky, manual, and there can be differences in terms of um, lab reader, people interpreting these tests. So yeah, I think either way, and again, in discussion with mom is helpful.
And also the follow-up piece, right? Like
Yeah.
if you're definitely going to see this kid again and the mom really doesn't want to give the kid penicillin for whatever reason, like I could be persuaded, but in general, I would err on the side of just give a dose of benzathine penicillin G.
Agreed.
I think that sounds good too. And I honestly feel like that's often where we end up landing, at least in the public health side, where we often don't really know all the clinical details, is just a dose of Bicillin for protection in a way.
Yeah.
Okay, other questions? I think this is a fair point. It's confusing that the CDC scenarios only apply to birthing parents or mothers who have reactive RPRs and treponemal tests, meaning they don't really know what to do for someone who doesn't have a prior syphilis history, has a non-reactive RPR, but is tested by the reverse sequence algorithm and has 2 reactive treponemal tests. They're not really in the CDC scenarios, although honestly, if you read farther down, if you get all the way to the bottom of the CDC section about congenital syphilis, which I know there's a lot in there, they do kind of talk about how to think about people who just have reactive treponemal tests and not reactive RPRs. But anyways, to our presenters, how do you think about that? Like, let's say mom has non-reactive RPR, but her EIA and her TPPA are both reactive. And let's say you don't know this until delivery. Like, how do you deal with the baby in that situation?
Dr. Partridge, what would you do
Yeah,
with the baby?
I mean, I would get an RPR in the infant. And then yeah, that's so tricky. All of these are so tricky. These are really good questions. Um, so yeah, I think in terms of so basically we're trying to assess risk in mom once again, right?
Yeah, I mean,
Um,
I think in this case, like, let's say your reverse sequence algorithm says that like this mom has late latent syphilis. You did not know that mom has late latent syphilis until delivery. Late latent syphilis is less likely to transmit in utero compared with syphilis where the reactive you have a reactive RPR,
I
but
mean,
it still
they
means untreated syphilis in pregnancy for the
yeah, they touch on it a little bit. I mean, you know, in the algorithm where you get to that point where it's like, okay, this patient had, well, no, I guess that would be scenario 3 because we think that this person had treated syphilis. I mean, I think
yeah,
that if you have someone who has a non-reactive RPR, but their TREP test is positive and they've never been treated, then it could be untreated late latent syphilis. We have to assume that, and we have to go by the scenario 2.
and get a
Um,
workup and
yeah.
baby.
There is this one paragraph. I've read these guidelines too much. There's one paragraph that's if you're reading the guidance on the CDC STI treatment guidelines, the paragraph above scenario 3, which is like the last paragraph about scenario 2, it does say that if the infant's RPR is non-reactive and the clinician thinks that congenital syphilis is very unlikely. So if both mom and infant are non-reactive, that you could do just a dose of IM penicillin without the workup, and then follow-up would have to be done to make sure that it stays non-reactive. You could do something like that. But it doesn't say just like pretend like this mom doesn't have syphilis, you know?
Right.
Yeah.
No, I think you're right. It sort of pushes mom into or to pushes baby into category 2
Yeah.
and requires a workup unless baby's non-reactive, like you're saying, Roz, and you can get them back and then you could do then the
Yeah.
odds of having CNS infection would be pretty low.
Right. And Kelly, like you said, the likelihood of vertical transmission in the setting of a non-reactive RPR is very low. Like RPRs are um, sort of a proxy for treponemal burden. And so, but I mean, these tests are not good tests. They're the best we have.
Yeah.
Yeah, that's one reason why syphilis
But
is so complicated and use
yeah.
STD-CCN. I do know we will not have, and now we still have 19 questions in the chat. We
Oh
will not
my.
have time to
Oh,
get to all of these. We'll keep going for a little bit longer. If you have a specific patient question, please do use STD-CCN as a resource because we can help you with individual cases there. There are several questions about this next topic, though, which I know there's one around which there's much debate. Let's say in a person who is pregnant, a patient who's pregnant who has a history of treated syphilis, and they've gone from non-reactive to an RPR of 1 to 2 at some point in pregnancy. 1 to 2, non-reactive to 1 to 2. Is that a fourfold increase? Have they been reinfected or not?
I would say it depends on like everything in syphilis. It depends. I think it depends on the lab. Like, was this done at the same lab? That's always a question. So you can look into things like that. What was the interval from the non-reactive to the 1 to 2? I think that there's a couple. Technically, if it's 2 dilutions from non-reactive, 1-to-1, 1-to-1 to 1-to-2, that is technically a fourfold increase. But it could also be that someone is zero fast at 1-to-1, and then they drop down to non-reactive, and then they go up to 1-to-2, and they're sort of hovering. So I think you, again, need to put it in the context of the patient and, see what their risk factors are. When was their last possible exposure? And you can always retest them in 2 to 4 weeks and see if it's still at 1-to-2 or if it's gone back down to 1 to non-reactive. You can always retest them if there's a low suspicion.
It's sustained, right, Roz?
Yeah, you need it to be you need a sustained increase for 2 weeks or more.
Yeah, that's so tricky.
It's super tricky. I don't know, Elizabeth, if you have other thoughts on it.
No, those are exactly my thoughts. And with the infant as well. I mean, what's tricky is if that happens at delivery and then you don't have the 2 week, the benefit of the 2 weeks. So then to retest, you have to make a decision for infant. But it's all of what we've been talking about. It's just not a great thing to have an algorithm for. You have to do everything, the test, the timing, the lab, the talking to mom, assessing risk factors, all of that together to build a picture. And then it comes down to what level of risk are you comfortable with and follow up and all of that. So, yeah.
Yeah, I will say for people who are looking for a definitive answer on this, we have been told at California DPH that the CDC is planning to officially say, for surveillance purposes, that in someone with prior treated syphilis, non-reactive has to go to 1-to-4 to be a fourfold increase by surveillance. That is not the same thing. It's not the same thing as clinical management. And I want to be very clear on that point.
Yeah.
If you have somebody who you think has been exposed, you think they're at risk of being exposed, and they go from non-reactive to 1-to-2, at minimum, I'd be bringing them back in 2 to 4 weeks to recheck. And if it was really close to when they were meant to deliver, I would probably just go ahead and treat them and also bring them back. So I'm just trying to be clear. Clinical and surveillance are not the same thing here, but we are expecting sometime after June at the CSTE meeting that this will officially be the position that you have to go to 1-to-4 by surveillance to meet criteria of a fourfold increase from someone who is non-reactive and has had prior treated syphilis.
Yeah. And if there's and Kelly, it's a good point. If there's a risk, if there's any concern about reinfection, the treatment is a single dose of penicillin for that potential reinfection. So you can always bring them back and do empiric treatment and test them again as a day of treatment test. And if it's back down to non-reactive, then okay, you treated them and it turned out it was just an aberrant titer.
Yeah, I mean, for the kids, it gets a little tricky because the workup is a little more involved in the implications of that. We, at our institution and others, getting an LP on an infant, it's not an easy thing to do. And if you aren't able to get it, then oftentimes, you've got an incomplete workup and it becomes difficult. So it's challenging.
Okay, I know we only have 2 minutes left. I do want to ask one pressing question, which is my own question, actually. Maybe some others in the audience have it too. I don't know. But it's for Elizabeth P.
Mm.
My question is, I know what the CDC guidelines say. I have read them. Scenario 1, baby clearly meets, say baby's RPR is fourfold higher than mom, their exam is consistent, you're pretty sure this is going to be a baby that you're going to treat with 10 days of IV penicillin.
Yeah.
Why do we need to do the workup?
I know.
What do you get from that?
I know. I was thinking about that question on the way in the car. How am I going to answer when someone... So no, I think here's what I think, because I've gone back and forth about this myself. An LP, what does an LP tell you in that infant? That if an LP is interpretable and positive, and that infant has CNS disease, that may qualify that infant for further follow-up in a neuro sense. So So like if the baby isn't so if babies that are premature, they can be shuttled into, they tend to be shuttled into an developmental risk sort of clinic. Um, and infants who have bacterial meningitis also can be referred to developmental high risk infant clinic. Um, so that is one possible reason that I can think of to do the workup beyond surveillance, right? Just strictly speaking from a clinical standpoint. Um, a CBC, just for congenital syphilis, they're going to get a CBC anyway if they've got congenital syphilis, because they're sick and that's part of what we do in the NICU. Long bones, we don't usually follow long bones, So if you've got a patient with a positive bony finding in, that they're getting treatment, we're not going to repeat those long bone films. So I think what I would say is I share your pause in terms of, do they really, if they're going to get 10 days, do we really need to be putting them through these studies? And I think from a surveillance standpoint, it's kind of interesting. From a clinical standpoint, I don't see any real benefit or follow-up that would come from doing a long bone or a CBC. Potentially, you could have some developmental neuro follow-up if that patient has congenital syphilis meningitis. But if we're tracking these babies in normal routine care, if there's developmental delays that come up, they're going to be given follow-up anyway. So I wish I had a better answer.
Okay, but you feel like at least the LP could have some utility in terms of ruling out other diagnoses and for follow-up for those babies. Am I
Well,
interpreting that properly?
I I think what I would say is, um, in some circumstances, um, if a baby, in some circumstances, if we know a baby has a bacterial meningitis, we know that the baby has syphilis meningitis, that baby could be shunted into closer follow-up from a neurologic standpoint.
Okay.
Um,
Like frequent neuro checks or
yeah,
something.
yeah, there are like we have at the Mine Institute here at UC Davis. We have a high risk infant clinic, and they're followed for developmental outcomes. Um, if that baby had, intrauterine drug exposure, that baby would be going anyway. If the baby was premature, that baby would be going anyway. But say there's a full term, otherwise healthy infant who has congenital syphilis CNS infection, that might prompt that kind of follow-up. But that they could also, yeah, it's tricky because half the time, or sometimes the LPs aren't diagnostic, and so you've just put that infant through that LP and they're getting therapy anyway. So the new guidelines, we now no longer have to do follow-up LPs, right? If we have an infant that we know has CNS infection, we used to have to do a follow-up LP at 6 months. We don't do that anymore. So it'll be interesting to see which way the guidelines go, if that continues to be a recommendation or not.
Cool. Okay. Well, thank you so much and for indulging me on that question.
Yeah,
If you're in
thank
the
you.
audience and you did not get your question answered, please check out STDCCN if it's about a patient. I'll put my email in the chat too if you have any direct questions, and I can connect you to Roz or Elizabeth P with their permission if there's specific questions for them. And with that, I want to thank Roz and Elizabeth P for giving this excellent presentation on behalf of the California Prevention Training Center at UCSF and the California Department of Public Health. Really informative. You're getting a lot of kudos in the Q&A, and we'll see you next time. Bye, everyone.